support for patients. So there's 4 types of infusion-related reactions. The first one is a standard infusion reaction. Then you have your type 1 hypersensitivity reaction, which is either IgE mediated or non-IgE mediated. There's anaphylaxis, and then lastly, there's cytokine release reactions or cytokine release syndrome. Standard infusion reactions are usually mild, they're reversible. They may represent more of an irritant. The mechanism's unclear, but usually it results from antibodies interactions that release cytokines. Most of these reactions we'll see with monoclonal antibodies. The most common fever, shaking, chills, flushing or itching. Sometimes you'll see elevated heart rate or blood pressure can kind of go either way, hypotension or hypertension. Trouble breathing, chest pain, back pain, or abdominal pain. Sometimes patients also get nausea, vomiting, or diarrhea. The next one, the hypersensitivity reaction. These are unexpected. They can occur like 6 minutes into an infusion, or they can occur within minutes of infusion or 6 hours after. They are often mediated by the immune system. They're usually allergic and mild to moderate. This is caused from mast cell or basophil activation. It causes symptoms like flushing, itching, hives, angioedema, wheezing, oxygen desaturation, and then cardiovascular collapse. Anaphylaxis, of course, is the big one, the one we never want to see. It's uncommon with some chemos, but you can still see it with platinum drugs like cisplatin, carboplatin, oxaliplatin, taxanes, etoposide, bleomycin, cytarabine, procarbazine, liposomal doxorubicin. There are some monoclonals that also cause anaphylaxis, like rituximab, which is about 5% or more. Trastuzumab is rare, but it has happened, and cetuximab. Epinephrine is your most effective treatment for anaphylaxis. It should be your first drug given. If you have any doubt if this is anaphylaxis or a reaction, just give the epinephrine because it's the best way to prevent death. So, and the IM dosing is what is recommended and not IV because it has less risk for cardiovascular complications. And here on the bottom, I just wanted to highlight this because we have had similar problems happen here where we have pregnant women coming in, they're getting iron. People are hesitant to give epinephrine. It is safe during pregnancy. And once again, we're trying to prevent death and save lives. The last type of reaction is the cytokine release reaction or cytokine release syndrome. This is developing after cells are damaged. So then you have that increase in inflammation from cytokines and interleukins. So CRR, the release reaction, is acute infusion related. It's usually mild to moderate, and you can resolve it with treatment. Um, Typically, we can see that with monoclonals, or you can see it with oxaliplatin. Now, CRS is more serious, cytokine release syndrome. It can have long-term effects. It can be severe, life-threatening. A lot of times we see this with CAR T cell therapy. We have patients who get CAR T and they'll come in and they have a checklist they do multiple times a day. If there's any concern for cytokine release syndrome, they are admitted to the hospital. For most patients, though, symptoms are less severe: mild fever, tachycardia, chills, nausea, generalized aches, headaches, rigors, and pain. Here's our fun little graph just to take us back to our pathophysiology days. So this gives you the different types of reactions and their triggers. So as you can see, chemotherapy, monoclonal antibodies can really cause any of the reactions. And then it just shows you the activation of if it's a mast cell or for cytokine release, it's a T cell, or you can have a mixed reaction where you're getting both. Below that, we kind of go over some symptoms here. Really, the symptoms we always see with reactions. You know, some patients will complain of chest tightness or shortness of breath. They'll look flushed. Sometimes with your monoclonals, you'll see them chilled or having rigors. Um, all of these kind of symptoms just lead us to stopping the infusion, treating the situation, and going from there. What is our next step for care? For reactions, it's important to grade the type of reaction. A lot of places try to use a standardized procedure just so for documentation purposes, you can look back and everyone's kind of using that same system. So these are two tables from the immunotherapy, chemotherapy guidelines book. Just to kind of summarize, a mild reaction can just be skin. It can just be itching, angioedema, so that would be a grade 1. Grade 2 is moderate. Usually there is some respiratory involvement or nausea, vomiting, dizziness, chest or throat tightness, abdominal pain. So grade 3 is severe. So that's usually you see hypoxia, hypotension, or maybe altered mental status, cyanosis, all of those things when you're talking a severe reaction is going back to anaphylaxis. So then this next table is kind of that same grading system. Then you're grading the severity of the reaction. Of course, you see in the middle, if it's anaphylaxis, you've still got it's grade 3 or higher. Of course, hopefully we never have grade 5 because that's death. That's kind of like the ECOG status. We don't want that. Um, Usually with an allergic reaction, the lower grade, you have less interventions needed than the higher grades. You're talking, we're giving more medicines, we're giving IV fluids, we're offering more support with oxygen, etc. So the next couple of tables are a little bit overwhelming, but I just wanted to highlight some of the medicines that are most common for reactions. The first three here are typically we see with HER2, it's anti-HER2 therapy. So a lot of breast patients. Now with next-gen sequencing, you may see it with patients with other cancers as well. So pertuzumab has a 13% frequency of reactions, but they're usually grades 1 or 2. Pertuzumab and trastuzumab, which we have the sub-Q preparation, which is Phesgo, is 21%. It's not as high of a risk as IV, but it can still happen. So it's recommended that you just monitor those patients after the initial dose and even with the subsequent. Trastuzumab can be 40% with the first infusion. So we do pre-med and we usually give that first infusion slower. And then the next subsequent infusions can be given a little faster. Okay, this looks crazy. So there's a lot of monoclonals on here that basically all of them you can pretty much give pre-meds to hopefully prevent the reaction. Of course, the most common that we probably see is rituximab. It has a 50% risk of reaction. It's usually the first infusion. Because we give a titration dose, sometimes you may not see that until they're about 2 hours into the infusion. The other one that I wanted to mention was cetuximab. So I work in GI oncology. I honestly have seen very few cetuximab reactions, but it's more common than I thought. So that also recommends pre-meds, a post-weight, or you titrate that rate to do it longer at first, over 90 minutes. Then here's the common chemotherapies. There's other chemotherapies that cause reactions like bleomycin or etoposide, but these are more common. The platinum drugs, so carboplatin, oxaliplatin have a more common reaction than cisplatin. Typically with both of these drugs, you're going to see the reaction later into their treatment, usually cycle 6, 7, 8, or 9. Um, Interestingly enough, with carboplatin, a lot of times we see that with gynecological patients, and they are at a higher risk for reaction if they have a BRCA1 or 2 mutation. Also, people who have had relapse disease or have a higher tumor burden can also react more often. Also, we have the taxanes on here, so docetaxel and paclitaxel. Both of those, it's a question if it's drug versus the vehicle. So with docetaxel or Taxotere, they use polysorbate 80, which is a solvent for the medication. That also is used in Emend, and I'm sure some of you have seen allergic reactions with Emend because it's the same solvent. So with Emend, we just would not use that drug anymore for nausea. We try something else. With docetaxel, usually pre-med up to 3 days before chemo with a bunch of steroids before they come in. If you don't do that the day of in the infusion center, they'd get a bunch of steroids. So paclitaxel or Taxol, kind of same thing. Its solvent is cremophor, so the question is if that causes the reaction or if it's the actual drug. Typically, you see these reactions in the first or second infusion. Pre-meds are recommended. Usually with all pre-meds, it's sometimes if a fever is a risk, they'll say an antipyretic like acetaminophen. You'll do antihistamine and then a glucocorticosteroid. So this is just a summary of different drugs we can use for treatment of infusion reactions. Of course, if you notice wheezing, stridor, cyanosis, severe hypotension, your first step is epinephrine. The dose ranges from zero point 0.1 to zero point 0.5 milligrams. You can repeat that every 5 to 10 minutes if you need to. Sometimes with epinephrine, you are going to have to repeat it because it wears off fast and you still have the drug in their system. So for hives, itching, cough, flushing, swollen lips, we will use antihistamines. So you have H1 and H2 blockers. So Benadryl and famotidine or Pepcid. Those are in our like emergency kits to give for infusion reactions. So Benadryl is 25 to 50 milligrams. Unless the reaction's severe, it's best to start low because a lot of times you can really sedate somebody, especially if they've already had Benadryl as a pre-med as well. And then you're dealing with low blood pressure just because of sedation and not necessarily the reaction. Of course, if people are short of breath, they've dropped their oxygen saturation, we're going to place them on oxygen. We're going to use albuterol. Depending on your facility, you may have a nebulizer or an inhaler. The only contraindication is, of course, if they're tachycardic, their heart rate's up over 110. I would not use the albuterol because you're just going to make that heart rate worse. For hypotension, you can always give a normal saline bolus. Usually you start at 500 milliliters, like over 15 minutes, but you can give more if needed. Moderate to severe reactions will also receive a steroid. Our steroid of choice is hydrocortisone, 100 milligrams. Other places will use methylprednisolone. Also, sometimes Rigers, which typically is a monoclonal antibody reaction, you can use meperidine or Demerol. You can give 12.5 milligrams once via IV, and then if the Rigers haven't resolved, you can give it another time. So this is the infusion reaction protocol that I took from our policy for WVU medicine. It kind of just goes through everything that happens. So at the beginning of symptoms, nursing would stop the infusion and they would page a provider, us or a physician or a fellow. If oxygen saturation is down, they can place oxygen. Recommended to monitor vital signs every 2 minutes until stable, and then you can do that every 15. You can start normal saline at a keep open rate or 100 milliliters an hour. Sometimes if people are hypertensive, I'll just have like the fluids running low, like 20. For mild reaction, so that's defined as itching, hives, rash, nausea, chills, flushing, you would only give the Benadryl and the Pepcid. And you can repeat the Benadryl in 30 minutes if you need to, if their symptoms haven't resolved. For moderate reactions, so shortness of breath, wheezing, chest tightness, you're going to also add to that Benadryl and Pepcid hydrocortisone, and then you can also have the albuterol if you need it, if they're wheezing. Severe reactions, so we're talking about anaphylaxis, if they've like decompensated, so you've got severe hypertension or respiratory distress, you'd administer epinephrine first. It's always given in the IM in the thigh, and then you would follow it with the Benadryl, hydrocortisone, and Pepcid. And then severe hypotension, so greater than a 20% drop in their blood pressure from baseline, you could start with a normal saline bolus. Then, as mentioned before, you still have Demerol if you need it for Rigers. So I just have some examples of reactions that I've seen. The first one is a taxane reaction. So this is classified as a type 1, which was related to the solvent. This was a 66-year-old female, was receiving cycle 1 of Taxol carbo. The Taxol started at 11:04. The patient called out approximately 15 minutes later. They were complaining of dizziness, feeling flushed. They were short of breath and had nausea. The infusion stopped, vital signs were checked and were stable, normal saline was infusing, so all 3 rescue meds were given, Benadryl, Pepcid, and Solu-Cortef. Symptoms improved, and in 30 minutes we were able to restart the infusion. We just restarted it at a slower rate and then titrated up. Moving forward, that patient did fine. Usually the taxanes is going to be the first or second cycle. Once you get them through that, they usually can go on and tolerate them. All right, we have platinum reactions, so IgE mediated. This was a 68-year-old female, cycle number 9 of carbo. So they've had 8 prior treatments, so we know they're at a higher risk to have a reaction. Patient complained of chest tightness. They were unable to breathe. They were red all over. Infusion stopped. Vital signs obtained, noted hypotension and hypoxia. So 2 liters of oxygen via nasal cannula. A fluid bolus was started. Because this reaction was more severe, they received 50 milligrams of Benadryl, 20 of Pepsid, 100 milligrams of Solucortef. Usually with platinum reactions, we do not re-challenge same day. So a lot of times with these cancers, they don't have other treatment options. So sometimes we do want to continue with that drug. So then these patients are entered into a desensitization protocol. A lot of times that's given in the hospital. So they take the total dose and it's divided into smaller doses. So you start with the first bag, which is like a hundredth of a dose, and then a tenth of a dose, and a third of the dose until they get that total dose. A lot of times, if they tolerate that inpatient for one cycle, then you can bring them outpatient, but it's still the desensitization protocol. So Rituxan reaction, 70-year-old male receiving R-CHOP. This was cycle 1. They had a large tumor burden, so this is considered a cytokine release reaction. The Rituxan was being titrated. This patient at their 4th rate increase, they complained of feeling unwell. They were chilled and had rigors. The infusion was stopped. Normal saline was infusing. They were given Benadryl, Pepsid, Solucortef. Demerol was given for the rigors. Demerol, the policy says 12.5 milligrams. I'll be honest, I have rarely got rigors to go away with 12.5. You normally always need to repeat it to the 25. Just be prepared. It's kind of like you just always have all your things out and ready, so that way you don't have to worry about nurses running back to a Pyxis to get more. Albuterol inhaler was given twice for wheezing. The patient did have a past medical history of asthma and recent COVID, so their respiratory symptoms were a little worse than average. Once symptoms resolved, they were able to complete their Rituxan without issue. So just some highlights or reminders at the end of this. When you have a reaction, think about the pre-meds they've already received. Back to the Benadryl. You might really over-sedate somebody. So if they've already had 25 or 50 milligrams of Benadryl as a pre-med, you might only want to give 25 if their reaction's mild to moderate. Past medical history, sometimes like COPD, they're going to be wheezing or they're not going to sound well or they might have low saturations, but that could be their baseline. That doesn't mean they're in respiratory distress from the reaction. So it really helps to know what the vitals were prior to the reaction. If you're ever doubtful about restarting an infusion, you can always get in touch with the attending and see their opinion. Also, trust your gut. If something's telling you not to restart it, then don't restart it. Iron infusion reactions. So, we're kind of programmed to give Benadryl. I know Dr. Merrill here for his iron, he has it very specifically in his plan. There is no Benadryl, that they prefer you use Claritin instead, just because the Benadryl can contribute to hypotension and make those symptoms worse. And just once again, if you think it's anaphylaxis, give the epi, give it in the thigh, don't give it IV. These are my references for your information, and that's it. Are there any questions?
Brenda, we had one thing in the chat, which Eugenia just came off mute, so I can let her speak to it since you would be much more equipped to talk about it than I would.
Hi, Gina.
Hi guys. It was just noted yesterday. We read it in an ONS form, or maybe the day before, but relatively close, that meperidine is likely coming off the market. And so for Rigers, it's going to probably be clonidine or tramadol, and both, of course, PO, but they still have a fairly quick onset. And I think that's going in front of a pharmacy committee meeting somewhere soon.
Yes, yes, you're right. I should have had that in there. I had seen the email about discussing the meperidine and removing it from the protocol. So yeah, those changes will probably be happening soon.
Thanks for a good presentation. It was really good.
Thank you for your input.
Are there any other comments, questions? All right, if there isn't, thank you everyone so much for attending. Again, if you have not completed the CME form, please go ahead and find that link in